First of all, I want to thank you, the organization, for allowing me to present my experience here. It's always a pleasure to see my friends from Chongqing HIFU and all of you, professors and doctors that share this nice experience of working with non-invasive ablation, focused ultrasound, HIFU, which is one of the best medical technologies that we can have today to fight cancer. To fight tumors. So my experience, as you will see in this presentation, and some ideas that how we have to progress and what's the future expecting to all of us. Let's see. So the purpose of this presentation is to clarify all the questions that probably are the most difficult to see in liver and pancreatic tumors. And because this is becoming now a very interesting field for different companies, different groups of research, to see if with our experience we can help them to not to go through all our learning curve and save them time and resources. Well, this is our experience. The last 12 years, we've been dealing with focused ultrasound, with HIFU, with the JC from Chongqing HIFU and the JC200, and both devices are excellent from our point of view. And we always have deal with the concept of trying to control local disease with non-invasive techniques, and then that this control of local disease can help us to manage the systemic disease. We've done in these last 12 years around 238 malignant tumors, is more than 250 now, and around 90 primary and metastatic liver tumors and 85 non-resectable stage 3 and 4 pancreatic tumors. So in talking about the liver, this is our first study that we included in the first 40 patients. We include patients that were not candidates for surgery or other ablation available, not radiofrequency, not microwave, because that was the standard treatment at this point. And all the patients were allowed to do their systemic chemotherapy before or after our procedure. Mainly we did 25% primary tumors and 75% metastatic tumors. Only a few percentage of patients did not have chemotherapy, and the majority, 80%, had chemotherapy. And this is the survival course, analyzing the first 40 liver tumors. Total treatment timings were between 60 and 180 minutes. The difficulties were related to patient positioning, access to segments 7 and 8, as our first speaker showed, that were the most difficult situations. But access to deep lesions is feasible with HIFU, access to segment 1, access to tumors close to inferior vena cava. The responses were very successful, 92% in all cases. Mostly with no complications, 85%, and a small percentage of complications with burning of the skin and 1 hematoma. And in this case, we had to deal with, resecting and using plastic surgery to cover the defect when we did a burning of the skin. The survival curve shows that is about around 30% at 5 years follow-up of these patients. Going towards the pancreas now, which is probably the most difficult scenario that we have in these cases, and probably what makes HIFU ablation the standard of care, or that is going to become the standard of care for tumors that are not resectable. So pancreas tumor is a priority because of the incidence prevalence of these tumors. There is increasing in the world. Median survival is around 18 months. 5-year survival is around 10%. Most of the cases are diagnosed when there is no resection possible. And there is around 450,000 deaths per year worldwide. The anatomy is very difficult, and there are no gender or race-related specific difficulties. We see here how we see the treatment in a JC treat in a JC focus ultrasound HIFU device. And here we see the response. Let me show better with this. We see here the stomach, and going towards the stomach, we can ablate the tumor in the head of the pancreas. So what we did in this case is try to make a comparative experience study. So we had our cohort of patients, and we compared with a retrospective cohort of patients treated at the same institution at the same period of time, only with standard chemotherapy regimes that were used by our medical oncology colleagues. There was a 7 years observational retrospective comparative cohorts study, and mainly were patients with stage 3 and 4 pancreatic tumors that were treated with the standard chemotherapy at that time. That was chemotherapy with the main combinations. We did focus ultrasound plus chemotherapy 57 cases, and the control group 58 patients treated with similar combinations. The chemotherapy combinations were gemcitabine combination, most of them 58%, and others the rest. So the responses were seen in 82% of the cases. There were 12 complete responses. We see 21% of complete responses after treatment with the combined treatment of HIFU plus chemotherapy. What a small set of complications: 2 pancreatitis, 2 skin burns, and 1 patient died of a delayed duodenal perforation that was not detected because the patient went out of our facility, went to another hospital, and that there was a delay on the diagnosis in this case. As we can see here, we see here the survival curves with the difference, the survival analysis between the group of chemotherapy alone versus the group of chemotherapy plus HIFU shows a statistically significant benefit for the group of patients treated with focus ultrasound HIFU plus chemotherapy. And the multivariate analysis, the hazard ratio is 0.45. That means that patients treated with chemotherapy plus HIFU have a 45% less probability of dying during this follow-up period, which is very interesting. This comparison that needs to be reinforced with studies, with prospective studies, but as a way of showing that we are in the right way of doing with this case. So that what we can consider that it's I would say the roadmap that we should do, and what you should achieve this is 2 registries. This is a project of a registry, of a pancreatic cancer registry, international registry, that's being done by the Focus Ultrasound Foundation in the US, with all different facilities that treat pancreatic cancer with HIFU. And the objectives are collect data and see if with this collection of data we can prove that focus ultrasound plus chemotherapy in a prospective way is the standard of treatment. Now, what I'm going to explain is what we can think and what we can show that the problems that we can face when dealing with the patients can be solved in the clinical site with the devices that we have. So we have the problem of the pancreatic cancer basically is the tumor microenvironment, the fibrotic tissue that surrounds the pancreatic tumor, the difficulties with cancer cell recognition because this tumor is very well protected from the immunity, and the delivery of treatment is difficult to reach the tumor. The immunity is not very well awakened when it's trying to confront the pancreatic tumor. And we may think here that do we need an ablation, or we just need tumor disruption with HIFU that allows other treatments to penetrate in the tumor and complete the ablation that we're doing with HIFU. So we have to respond with this, with research in the role of hyperthermia, if it's need to be an ablation or can be a low hyperthermia can be of use. How can we deal with this tumor microenvironment? How can we disrupt this tumor microenvironment and the fibrotic tissue to allow the drug delivery inside the tumor? How can we enhance the immune in front of that? And with HIFU, we can obtain some abscopal effect, which is the effect that we can obtain together with the HIFU and the immunity against the tumor. And at the end, the tumor disruption, which should be our main objective. So this is what we face in the systemic, but then there's local problems. And the surgical problems that we face is the possible interference between the small bowel of the colon, the tumor invasion of the duodenum, the placement of a biliary stent that can make difficulties in treatment, the obstruction post-treatment of bowel, biliary, or pancreatic ducts, and the invasion of vessels. And to do that, we need to previously obtain difficulties and avoid bowel interference. So positioning very well, use of water balloon, do not treat the duodenum affected cases because there is a risk of perforation or delayed fistula formation. Always treat after stent placement in the pancreas head tumors. And then we can treat with different angles of sonication to cover the back space of the stent. And do not treat vessels if there is a thrombus inside these vessels. So the recommendations are to use in anesthesia techniques of respiratory gating, avoid shallow breathing volumetry. So use that the tumor is as still as we can have. Do not treat surgical cases. Stage 2 and 3 or borderline patients are the best candidate. Metastatic cases are the best candidates. And there is an area between the head and neck and the body of the pancreas, what probably is when 60% of the tumors are presented. And here is when we can obtain the best results. And what not to do: treat tumors close to the duodenum with the risk of fistula, use a water balloon, NG tube placement, and gas minimizing procedure as helpers to our treatments. So in the pancreas, we don't have to expect 100% ablations with tumor margin. We have to reinforce the strategies to aim at the tumor microenvironment disruption and work with protocols of combined chemotherapy, targeted therapy, or immunotherapy. And that would be the best area where to treat if we have a tumor of the pancreas. So the ideal candidate would be a tumor at the stage 2 or 3 that had partially responded to the first chemotherapy line, that has a tumor placed in this area between the head and the body of the pancreas, that is not bigger on the pancreatic borders, and there is an absence of any bowel structure between the tumor and the skin. So if we had to write a letter to Santa Claus and ask what would be our future and what we want them to bring us. So we have to consider that the tumor is a substantive entity. The disease is a life inside another life. The disruption of this with less harm to the individual is probably our main objective. We have to enhance our own defensive systems, and we have to deal with cancer stem cells. So we have to break the tumor from the inside. We have to adopt the cancer hallmarks to help us deal with this tumor. We have to face the difficulties for tumor nutrition and cutting ways of delivery of nutrition to this tumor, help with the immune attack, and breaking the structure inside the tumor. So this is all. I am ready for questions. Again, thank you for you listening to me at this presentation. And this is a group of our team that been dealing with our colleagues GYN with the ablation of fibroids. And thank you, and I'm ready for questions.